Bismillahirrahmanirrahim. I am Dr. Ali Khairuddin, orthopedic surgeon, lecturer in Ninawa Medical College. This is the first lecture of orthopedic and fracture. I want to say welcome to you in the beginning of this year, 2020. We must know what we mean by orthopedic. Orthopedic is a branch of surgery that concerned with bone, joint, muscles, tendons, and nerves. This branch deals with the skeletal system and all that make it move. We have conditions that affect these structures fall into 7 easily remembered pairs. So we receive a congenital and developmental abnormalities that can affect the skeletal system, also infections and inflammations of the bone and soft tissues, arthritis and rheumatic disorders. We have a metabolic and endocrine disorders that can affect the skeletal system, tumors and the lesions that mimic the tumors concerned together, neurological disorders and muscle weakness, and lastly, we have an injuries and mechanical dearrangements. In this lecture and in the following 2 to 3 lectures, I will talk about the principles of fractures and its management. First of all, we must know the definition of a fracture. A fracture is a break in the structural continuity of bone. The characters of the fracture depends on whether etiology. We have a traumatic, fragile, stress, and pathological fracture. The other character is the relationship of the fracture with the external environment. So we have an open and closed fracture. If the overlying skin remain intact, it is called a closed fracture or simple fracture. If the skin is a break, that means that there is connection between the atmosphere and the bone, so it is a compound or open fracture. In this picture, it is very obvious that there is a wound in the distal part of the left forearm with severe deformity of the distal forearm. Also, the bone exposed from the wound. This type of a fracture called compound fracture. Pattern of the fracture. We have a complete fracture. The bone is split into 2 or more fragments, transverse, spiral, or oblique. Incomplete fracture, here the bone is incompletely divided and the periosteum remain in continuity. This is usually seen in children. It is called the green stick fracture. Here the bone is buckled or bent, like a snapping a green twig. Etiology of the fracture. How the fracture happened. The fracture may result from the traumatic incidents, whether it is direct or indirect trauma. We must keep in our mind that direct trauma causes a fracture at site of injury, while indirect trauma, the fracture could happen away from the site of injury, like a twisting of the leg may lead to fracture neck femur. The other type of the fracture called a fragility fracture, usually seen in osteoporotic bone. Fragility fracture, some books say that it is part of pathological fracture, and here we regard as special type of a fracture. The other type called stress fracture, called also fatigue fracture. The lastly, we have abnormal weakening of the bone called pathological fracture. In a traumatic fracture that must are resulted from combination of forces, twisting, compression, bending, or tension force. The XI pattern may suggest the dominant mechanism. Twisting force causes spiral fracture. Compression force causes short oblique. Bending force causes fracture with triangular butterfly segment separated from the original one. Tension force causes transverse fracture. This description applies mainly to the long bone. As you see here in this picture, twisting force can cause short spiral fracture. Compression lead to short oblique. Bending force cause transverse fracture with butterfly segment separated from the original bone, and also tension force can lead to transverse. Very clear transverse fracture appear in this picture, and also there is compression force lead to short oblique. Again, spiral fracture can result from twisting injury, and bending force lead to transverse fracture with butterfly segment separated from the original segment. In this picture, it shows that there is comminuted fracture due to high energy injuries. Sometimes the trauma may lead to segmental fracture, that is means separated of a segment of bone from the original one, as you see in this picture. Also, this picture demonstrates different types of a fracture: oblique fracture, short spiral, comminuted fracture, and also in comparison to the compound fracture, that there is a wound extended to the fracture site. These different X-ray pictures show the transverse fracture of the distal part of the femur, proximal part of the femur, and also short oblique fracture and the spiral fracture of the tibia and fibula. Another transverse fracture pictures for tibia and fibula, for segmental fracture in the shaft of the femur, and the spiral fracture in the distal part of tibia and fibula. This is an X-ray picture of a segmental fracture tibia, also fracture fibula, with severe displacement of the fracture tibia, and this is a very critical condition. This may lead to what we call urgent complication, and it may end with what we call compartment syndrome unless early surgical intervention to prevent that condition from happening. This is an X-ray of the wrist of a child, immature bone, show that there is a transverse fracture line. It is called the green stick fracture or incomplete fracture. This is due to buckling of the cortex of the bone like a green twigs. So it is a green stick fracture. A cancellous bone, when subject to sufficient force, a comminuted crush fracture will result, usually seen in a spongy bone like fracture calcaneum and fracture vertebra. A Avulsion fracture may result when there is resisted muscle action that may pull off a bony attachment of the muscle. Here, we call this a fracture is a fracture olecranon. This happens after resistant extension of the forearm. It is type of intra-articular fracture because the olecranon articulate with the distal part of the humerus to form an elbow joint. The triceps tendon that attached to the proximal part of the ulna olecranon area tried to pull out the segment from its place and lead to the displacement of the fracture site. Fragility fracture. Fragility fracture usually results from low energy force. It happens in osteoporotic bone. Osteoporosis is a common disease in elderly and now is recognized as the major factor to raising the number of the so-called fragile fracture. The condition is characterized by loss of a trabecular bone mass and connectivity as well as thinning of the cortical bone. Some books regard osteoporosis as type of pathology. So when the Fracture happening in osteoporotic bone, it is regarded as a pathological fracture. Here we take it separately as a special type of a fracture called fragile fracture. The commonest fragile fractures called Colles fractures that happen in the distal part of radius. Femoral neck fracture, very common fracture in elderly people. Thoracic and lumbar vertebral fracture, also it is type of fragile fracture due to osteoporosis if it has happened in elderly people. Third fracture, stress fracture. Stress, or what we call fatigue fracture, can occur in metal and other materials due to gradual rearrangement of the molecular structures, which will lead to weakening of the metal and permit it to crack. A similar mechanism of cracks can occur in bone. When the bone subject to repeated stress, it will lead to what we call stress fracture. These fractures occur in normal bone, very important here, which is subject to repeated stress, typically seen in athletes or military personnel. The most common site is the tibia, fibula, and metatarsal. The great differences between stress and the traumatic fracture is that there is no single specific injury in case of fatigue fracture. The onset of pain is gradual and increased by activity, relieved by rest. On examination, there is local tenderness over the affected bone. In X-ray, X-ray finding may be normal at first time, and after 2 to 4 weeks, the radiological changes appear as a faint hairline crack surrounded by callus. Occasionally, if a biopsy taken from the callus may be mistaken to diagnosed as bone sarcoma. It is very important and mistake that should not occur if the feature of stress fracture are properly understood. Pathological fractures. Fractures may occur even with normal stress if the bone has been weakened by a disease that change in its structure. The underlying disease may be local, like in bone cyst, or generalized disorders of the bone, for example, osteogenesis imperfecta or pathological fracture may result from metastasis of malignancy or from the organs, like in carcinoma of a breast or carcinoma of a prostate, can metastasize to the bone and lead to pathological fracture. Sometimes benign bone lesion can weaken the bone and may lead to pathological fracture, as you see here in non-ossifying. Another anosteolytic lesion affecting the bone, causing weakening of the bone and lead to pathological causes of pathological fracture. We have a local disease that affect the bone, infection. Infection, one of the important cause for pathological fracture, infection of the bone called osteomyelitis. Benign tumor like chondroma, hemangioma, malignant bone tumor like osteosarcoma, Ewing sarcoma, or metastatic carcinoma, miscellaneous cause like simple bone cyst, monostatic fibrous dysplasia. We have general affection of the skeleton, congenital disorders like osteogenesis imperfecta, diffuse bone weakening in Cushing syndrome, tumor-like condition like multiple myeloma, and miscellaneous like Paget disease, polystatic fibrous dysplasia. How the fracture are displaced. After a complete fracture, the fragment usually displaced partly by the force of injury, partly by the gravity, and partly by the muscle that attach to the bone. Displacement usually described in terms of translation, that is means shifting, alignment means angulation, rotation or twisting of the bone, and the length means overlapping of the bone. How the fracture heal? Very important to know the healing of the fracture. The process of a fracture repair varies according to the type of the bone involved and the amount of movement at the fracture site. So, any tubular bone and in the absence of rigid fixation, healing process pass in 5 stages. This is called indirect way of healing. First of all, tissue destruction and hematoma formation. Second, inflammation and cellular proliferation that start 8 hours after the injury as acute inflammatory reaction and cellular proliferation. Third, callus formation, the proliferating cell, is potentially chondrogenic and osteogenic and start to form a primitive bone that is called woven bone, which will splint the broken bone and decrease its movement. The fourth step is consolidation after a few weeks, 6 weeks in upper limb and 12 weeks in the lower limb. The woven bone replaced by lamellar bone by active osteoblastic and osteoclastic activity. Lastly, remodeling the bone restore its normal shape and the medullary canal open through the process of resorption and formation. This occur over a period of months or years. In healing of a fracture under rigid fixation and compression, the bone heal without callus formation cross directly from one fragment to other. This is called the direct union. So the difference between direct union and indirect union, that the direct union, the bone healed without callus formation, while in indirect healing, the bone unite with callus formation around the fracture site. To demonstrate the process of fracture healing, when the fracture happened, there was bleeding around the fracture site with hematoma collection. Within weeks, this hematoma changed to callus and start to decrease the movement at the fracture site. After about 6 weeks in the upper limb and 12 weeks in the lower limb, this callus will change to lamellar bone. And lastly, after a few months to years, there is remodeling of the fracture. The bone start to regain its normal shape and the medullary canal start to open and the fracture line disappear. Now we must know the timetable for fracture healing. How long does the fracture take to unite and consolidate? This is an important question. The answer is no precise time. It depends on the age, a blood supply, type of a fracture, shape of the fracture, and other factors. Perkins can give us approximate time for healing of the fracture. It is called Perkins timetable. The key word is spiral fracture in the upper limb that is united within 3 weeks. And for consolidation, multiply it by 2, so it need about 6 weeks for consolidation. For transverse fracture in the upper limb, again multiply by 2, so it need about 6 weeks for union and 12 weeks for consolidation. In the lower limb, we started by 6 weeks for union in a spiral fracture, multiply by 2 for consolidation. And also for transverse fracture, again multiply by 2. So transverse fracture in the lower limb need 12 weeks for union and 24 weeks for consolidation. This is the expected time for healing, but there is a factor can affect the fracture healing. First of all, age of the patient. In children, the fracture usually healed faster than those in adult. Constitution of the fracture. Simple fracture with limited soft tissue damage heal faster than open and in severe soft tissue damage. Shape of the fracture. Spiral fracture heal faster than transverse fracture because of wide and big surface area in a spiral fracture. Site of the fracture very important in healing of the fracture. For example, intracapsular fracture neck femur heals slowly, or it will end with non-union, and this is due to a blood supply to that area. A more blood supply to the fracture means a quicker healing. A position of the fracture, if the two ends of the fracture is in contact and in good alignment, so the fracture will heal faster than if the two segments is displaced and separated from each other. Immobilization is very necessary for fracture healing, and excessive movement at the fracture site can cause general condition of the patients and disease like diabetes mellitus, renal failure, liver disease. Also, if the patient take steroid therapy, immune suppressant drug will affect the fracture healing, and the diet also play a role in healing of the clinical features for a fracture. We must take a history and then go to general examination, local sign, and then x-ray, and sometimes we need a special. From the history, usually there is a history of injury, followed by inability to use the injured limb. This is happening in a traumatic fracture. Be aware that the fracture is not always at the site of injury. A blow to the knee may fracture the patella, femoral condyle, and even a general sign. A broken bone is a part of the patient. So we must look for the patient in general. We must check the vital sign, for internal bleeding, for associated damage to the spinal cord, and also we look for predisposing cause in bone disease. Local examination is very important to the injured limb. We must look for the swelling, bruising, deformity, and the state of the skin, if there is wound or not. We must feel for tenderness, and also we must check the distal pulsation and sensation to exclude neurovascular injuries. After that, we try to move. Feeling of crepitus and abnormal movement at the fracture site, it is a sign of fracture. Checking for movement distal to the injury is very important in any injured limb. After look, After complete the examination, look, feel, and move, then we must take an X-ray for the patient. Very important is to follow the rule of two in reading an X-ray. Two views, two joints, two limbs, two injuries, and two occasion. Two views, AP and lateral view. Two joints, above and below the fracture site should be involved. Two limbs in children sometimes need to compare the injured with uninjured side. Two injuries in fracture calcaneum, sometimes associated with other injury like fracture pelvis or fracture in the vertebra. Two occasions, sometimes fracture scaphoid, not so clear at time of presentation. And if we repeat the X-ray after a few weeks, the fracture will appear more obvious. Again, X-ray examination is mandatory. Remember the rule of two. Two view, a fracture or dislocation may not be seen on single film. So AP view and lateral view, anterior posterior and lateral view must be taken. Two joint in forearm or leg. One bone may be fractured and angulated. Angulation, however, is impossible unless there is a fracture in the other bone or a joint dislocation. The joint above and joint below the fracture must be included on X-ray. Two limbs in children, the appearance of immature epiphysis may confuse the diagnosis of a fracture. X-ray of uninjured limb may need it for comparison. Two injuries, severe forces often cause injury at more than one level. Thus, fracture calcaneum or femur, it may associated with a fracture pelvis or a fracture. Two occasions, some fractures are difficult to detect it at time of injury, but another X-ray examination a week or two later may show the lesion very clear. A common example are scaphoid bone fracture, femoral neck fracture, lateral malleolar fracture, and also stress fracture and physical injury, whether they occur. If you look to this picture X-ray, there is no obvious fracture appear in this picture, but no comment on one view, so we need and lateral, anterior posterior and lateral view. In the lateral view, there is obvious fracture extended from the distal part of the tibia, directed downward to the distal lower third of tibia. So, two view is very important in detecting a. In this X-ray picture, there is a fracture in the proximal part of ulna, but the elbow joint not appear. Two joints. The first X-ray did not include the elbow. Was, in fact, a Monteggia fracture. The head of radius is dislocated and show the dislocation in the radiohumeral joint. Here, the two joint is very important to exclude associated injuries with the fracture. Two limb is very helpful cases, especially in children. We take an X-ray to the normal limb and compare it to the injured side. To exclude an injuries like this, it is a fracture in the lateral condyle of the humerus, and it is very clear if we compare it to the normal side. Two times, for example, fracture scaphoid, not so obvious fracture line here. We repeat the X-ray after 2 weeks, the fracture line become more obvious, and this is help us in diagnosis of special types of a fracture, like a fracture scaphoid bone, impacted fracture neck femur, a fracture and displaced in the lateral margin. Two injuries like this, fracture calcaneum, it may associated with like fracture in the thoracic or lumbar vertebra. Sometimes it is associated with fracture in the acetabulum or fracture in the pelvis. Sometimes the plain X-ray is not enough for diagnosis and take a decision for the fracture. So we need CT scan, especially in a spine fracture, or if the fracture extended to the articular surface. So there's an indication for CT scan in intra-articular fracture to decide what we will do. MRI in a spine fracture which threatened the cord, it is indicated. Sometimes we need radioisotope scan, especially to diagnose stress fracture or to diagnose undisplaced fracture. And thank you.